Hello, everyone. My name is Andrea Zotinka. I am a Circular Healthcare Project Officer at Healthcare Without Harm Europe. And today I will be moderating this session. Just to let you know, we have interpretation for this session. So if you go on the bottom of the Zoom window, you can see the little world image, and you can choose the channel with your language, the language that you need. We have interpretation in French, Spanish, Dutch, and Greek. I forgot for a second. So before we begin, I wanted to let you know that this webinar is part of two-session series. So we will have another webinar next week where we will focus more on harmful chemicals and health. And this will be particularly relevant for healthcare professionals working with children, infants, and pregnant women. So please register to that as well. It's, if you have time, of course. It's on 7 December. It will start at 4 CET. Also, for the nurses who are joining us today, we have continuing nursing education credits available. So if you need credits for joining this webinar, you can get in touch with us. You can get 1.5 credits for each webinar. I also wanted to talk a little bit about us. So if you do not know yet, we are Healthcare Without Harm Europe, and we are an NGO working with the healthcare sector to make it more sustainable. We have some action networks, and I invite you to check them out if you want to. If you want to join any of them, it is all for free. We have Global Green and Healthy Hospitals, which is for organizations, but we also have action networks for individuals, like the Nurses Climate Challenge, for example. So do check them out as well. Our Global Green and Healthy Hospitals network has 146 members in 25 countries across Europe. But this is just in Europe. We also have members from across the world as well. So it's quite a big network. Okay, so now we can go to the topic that we will discuss today. So why is it important to work on plastics and on waste in general in healthcare? So I feel that there is this disconnection in a way from the items that we are using. So in healthcare, but also in our daily lives. And we do not know where they come from. We do not know what materials these items are made of. We do not know who made them. And at the end of using them, we throw them away and they kind of just disappear. But again, we don't know what happens to them. And healthcare has this mission of healing, but unfortunately, at the same time, it also creates a lot of damage and harm, which is sometimes happening quite far away from us. So it seems a bit abstract, but this harm is real and does exist. It can happen to communities who live close to a plastic production site, and they are exposed to toxic chemicals every day of their lives, or communities who live close to incineration sites, who have to breathe this polluted air all the time. So these items that are being used in healthcare, in our daily lives, do have an impact somewhere far away from us, but also sometimes closer to us when we think about the harmful chemicals that are used in plastic, that can to which patients are exposed to. And we will talk about this a bit more next week. What I mean with all of this is that I think it is important to be aware of these risks that come with the items that are being used, and to be critical of the practices that are being done every day. So maybe ask the question, is this really needed? Is this item needed? Does this have to be single use? And so on. And yes, of course, there will still be a need for some of these items in healthcare, but they can be reduced quite significantly. And so this harm that is being done will also be reduced. So moving to plastic in particular. So as you know, we already have currently quite a big issue with plastic consumption and plastic pollution, but not only. And our plastic consumption is actually projected to triple in the next 40 years. So it is only growing. And you can imagine that if now we cannot really deal with it, it will be even harder for us to handle all this plastic in 40 years. Most plastic nowadays, I would say like 99% of the plastic that we are using is made from fossil fuels. So this can be oil and gas. Most often it is cheap shale gas from the US, for example. It can also be coal sometimes. And everything, all the negative impacts that we associate with fossil fuels and the fossil fuel industry can also be applied to plastic. And plastic across its life cycle can impact negatively both our health and our environment. And as I mentioned earlier, the healthcare sector is following the same linear models of consumption, of buy, use, and throw away, even when reusable options do exist and are safe. So we have to think a bit more about the impact of this model of consumption. As I mentioned, across its life cycle, plastic has an impact on the environment. So the life cycle starts at oil and gas extraction, which involves the clearing of forests, for example, or natural areas. It involves methane gas emissions. It involves a use of toxic chemicals, where again, the local communities and local ecosystems are very much impacted by it. Then there is refining and manufacturing. And this is a very energy intensive process. And here too, a lot of harmful chemicals are being used. At the product use phase, the impact on the environment can be from the microplastics that are being released, or again, from the chemicals that can also leach from the product. And lastly, at the product disposal phase, which I guess we are all aware of in the case of plastic nowadays when it comes to plastic pollution, but the impact can also happen when the plastic is incinerated, when it is landfilled, and also when it is recycled, because that too has an impact. And I see nowadays that there is a big focus on reducing the carbon footprint and going net zero, but this cannot be achieved without addressing plastic production and consumption on one hand, and in general, the consumption of single-use items, especially when it's not necessary. And in this image, which was created by the NGO CL, you can see the annual emissions from plastics life cycle as equivalent of coal power plants of 500 megawatts each. And you can see that in 2019, the emissions from our plastic use were equivalent to 189 coal power plants of 500 megawatts. And in 2050, these emissions will grow to 615. So a lot of our carbon footprint comes from our use of plastic. And here I won't go into detail, as we will talk about it a bit more next week. But as I said, plastic can also impact health at every stage of its life cycle. And you can check out the slides later and also the report that I linked below to see exactly how our health is affected. And of course, this is very relevant to healthcare because plastic can make us sick, but also in hospitals themselves, the patients can be exposed to the harmful chemicals that are present in these plastic items. And infants and children are particularly vulnerable to these chemicals. And there is already some research showing how these chemicals can affect the health. So here I linked only one, which showed that DHP, which is a chemical used in PVC IV bags and tubes. So this chemical can increase mortality and the risk of breast cancer relapse for patients who are treated using these products. So this is another issue that I think should be more visible to healthcare professionals. So now that I talked a little bit about the problem of plastic and waste, we can have a look at how it can be solved. And here is the waste hierarchy. This is a tool that can help us make choose the right actions in addressing our waste problems. And of course, the most obvious action that we can have to address the waste problem is to not create waste in the first place. And this can be done by following the upper half of this waste hierarchy. So through prevention, it is reducing, reusing, reprocessing, and repairing. So we at Healthcare Without Harm Europe are trying to focus our efforts on this part of the waste hierarchy, as we see that here there is the most potential to reduce the impact. And in the bottom half, it is where the product has already become waste and already the impact has increased. And here I wrote that recycling is not waste reduction, because still putting the items in the recycling bin, they are still waste. So I will talk a little bit shortly about the problems with recycling. But across this waste hierarchy, it is also important to look at phasing out the harmful chemicals that are present in these products to reduce exposure to patients and also to environment as a whole, and replacing these products with toxic-free alternatives. And now to talk a little bit about plastic recycling, because it is a very popular and kind of an easier fix that people propose nowadays. But unfortunately, this is not working so well so far. Right now in Europe, only around 14% of our plastic waste is recycled. So this is a very little number, considering that our plastic production is going to grow. We do not have enough capacity in Europe to deal with all the plastic that we are producing. And plastic also loses its quality when it is recycled. So it is not an infinite loop. The most it can do is maybe one or a few loops, and then it will still end up as waste. And I think a very important issue that we also need to talk about is the problem of waste shipments. So here in Europe, we are sending a lot of our waste abroad to other countries, passing our responsibility to others, and also minimizing their ability to tackle their own waste. And I recommend you watch this little video when you have the time. And of course, the toxic chemicals that were present in the initial product will still remain in the new products as well. So they do not disappear. Again, as plastic has a lot of toxic chemicals, it is not really compatible with recycling as part of the circular economy, which should be toxic-free. And here are some articles that expose this problem of waste shipments abroad. So here I left some questions that you can ask to kind of guide you in applying the waste hierarchy. It's really important to take them in order and not just jump to recycling right away. But for some examples on applying this waste hierarchy, you can go to our Healthcare Without Harm Europe page on plastic reduction, where we have a lot more resources. And we will hear now from our speakers for today. First, we will have Mahmoud Bouta, who is a professor of sustainable healthcare at Brighton and Sussex Medical School and honorary consultant and clinical green lead for University Hospital Sussex. Then we will hear from Nicola Wilson, who is lead practice educator at Great Ormond Street Hospital, and from Federica Piro, who is an anesthetic nurse. So you can use the Q&A function to ask any questions you have to our speakers, but I see that some of you have already used it. Okay, I will now pass the floor to Mahmoud.
Thank you very much for that introduction. So welcome, everybody. I'm going to talk to you, concentrate really on what creates a circular economy in healthcare and how we might try to enable that. I'll just try to share my screen. You can see my slides?
Yes.
Fantastic. Thank you. So my research interest really is in how we create a circular economy for healthcare products. And that includes plastics, but is more than just plastics. But I'm going to concentrate here today on some of the plastic products that we do use in healthcare. So you may be aware of the carbon footprint of healthcare, which the NHS in England has outlined. And this is a wheel, quite a famous wheel now, I think, of where the carbon footprint of healthcare in the UK comes from. And I think it's similar across other countries. And obviously what I'm concentrating here is the medical equipment here, which forms 10% of the entire carbon footprint. I use the example of the operating theatre, where we have done quite a lot of work on carbon footprinting, and that's really my clinical lecturer in sustainable healthcare, Chantal Rizan, who has done a lot of the research underlying this, but it exemplifies the sort of waste that we produce through this linear economy. So we know that the operating theatre is the most resource-intensive area of the hospital, generating up to 1/3 of total waste in a hospital. And it also has high energy consumption. And so a typical operation has the carbon footprint of this 150 to 170 kilograms of carbon dioxide, the equivalent of driving from London to Edinburgh in Scotland in a petrol car, so around 600 kilometers. And hotspots for this from our systematic review in the operating to include energy use. They include anesthetic gases, which I'm not going to be talking about today, but in particular consumable equipment. And so here's some data not yet published, but soon will be, I hope, looking at the products used in an operation and their carbon footprint. And we carbon footprinted several hundred products of some of the most common operations performed in the UK, but they'll be similar across the world. And what we found is in that red section of the pie chart is the production of single-use equipment that contributes, unsurprisingly, to the carbon footprint. So that is the reason we really need to concentrate on this single-use culture. And you can see overall, we found that 68% of the carbon of all products is used to the single-use products. That's both their production and the packaging that they come in. And this seems to be the same. Even if you take different approaches to surgery, for example, here's some data from the US where they compare different approaches to a hysterectomy, the removal of the womb. And if you do it through a vaginal abdominal approach, these are traditional open approaches. The carbon footprint is shown here of a single operation. But then as soon as you move to more complex procedures, such as a laparoscopic approach, keyhole surgery, or a robotic approach, the carbon footprint does go up, but the majority of the difference is due to the increase in the number of single-use equipment. So why are we using so much single-use equipment for doing the same operation? As we move to possibly, arguably, more advanced models of care, actually we see an enhancement in the number of single-use equipment that we use. And I have to question why this is. And it doesn't have to be this way. So here's some data from India compared to a cataract operation. So on the eye in the UK, the carbon footprint is similar to what you would find for a typical operation at 180 or so kilograms of carbon dioxide. But when performed at this center in India, it was more than 30 times less. And that's because they have highly efficient systems for operating, but they also reuse almost all of their equipment. And if we're worried about infection, actually, they reported their rates of infection after the operation, and they were lower than we report in the UK. So this is the best standard of care by any means. So my particular interest has become about, well, what's driving this? And we need to have an understanding of the underlying market dynamics of medical goods, which are different to the markets for other goods that we might see. So, for example, if I was buying a mobile phone, I would be the purchaser. Normally, I would be the purchaser, the consumer, and the user of that product. But in healthcare, we have this disconnect and diffusion of the supply chain. So the consumer is the patient, the user is often the healthcare provider, and the payer is often the health system. So the purchaser, the user, and the consumer are different things, and that can lead to a potential diffusion of responsibility, but also a diffusion of ability to change these structures. And so here we have the supplier, and we see that often with the interaction between the user and the consumer, what we are concerned about is, of course, the highest standards of care, and in particular, things such as infection and safety. And that's often what we are led to believe, that we are providing the highest, safest care. And sometimes that's associated with high cost and complex products, which are fantastic for delivering that care. But sometimes we wonder why those are single use. And between the payer and the user, it's often low cost and low complexity products at high volume. And when you're selling at high volume, it is usually the price that is the most important thing that determines this. So what this creates is a big industry around the globe, but also an industry that has some different drivers, if you like. So the high-cost products, they're often complex and multi-component, lots of carbon embedded in them because they are so complex. And recycling is difficult or impossible because they're often multi-component, they may be infected. And as we've already heard, recycling is of low priority. It typically recovers about 3 to 4% of the carbon footprint. So we must not concentrate all our efforts on recycling. It's part of the solution, but it's really not where we're going to create the biggest changes. What we find is that some of these have restricted or limited number of uses, and whether that's due to regulatory restrictions on reuse or whether there's economic drivers, such as coming from industry to promote this linear economy, or whether it's the way that we purchase things on short-term contracts, is also something that needs to be looked at. So what we find with the low-cost products, where we're asking for the lowest possible price, is we have free market economics, as we see in other sectors. And that means that we are really focused on price and getting the goods from wherever possible. So here, for example, are some bandages coming out of a factory in Mexico. And what we find is the bandages are all the same. They're coming off the production line. They're going into 6 different boxes. The box on the right-hand side here is a major US brand, I think no longer trading, but was a well-known US brand. And the box on the left is a local Mexican brand that you'll never have heard of, unless perhaps you live in Mexico, but it's exactly the same product. So a lot of the money is going into marketing to sell us this product. We also saw this during the pandemic. A company that produces gloves, Ansell, was producing gloves in its own factories in Malaysia, but during the pandemic, we know they used all these other glove manufacturers to produce their gloves for them. So it is free market economics. The problem with the free market economics issue is that you often, with outsourcing production to wherever is created, we don't necessarily get transparency. We don't necessarily get to protect worker rights. So here's some masks made during the pandemic and supplied to the US and the UK. Of course, these are plastics as well, spun plastics, and the plastics. And what we find is that they were produced using forced Uyghur labor from the Xinjiang province of China. And I hope many of you are aware of the genocide of the Uyghur populations that is being enacted, unfortunately, by the Chinese state. We also found that some of our gowns coming into the UK, again, made of spun plastic, single use, were made using forced North Korean labor, again, in China, over the border from North Korea. And these North Korean workers working in China had between 70 and 100% of their salaries given to the North Korean state. We also saw during the pandemic PPE, again, gloves, a huge amount of gloves, which is, again, is single-use plastic being produced in Malaysia, usually using immigrant workers. And I'm going to concentrate on that now just to show you what the realities of that are. So this is a factory complex of Top Glove, the world's largest manufacturer of gloves. There are 30 factories here producing in these sorts of conditions. And the factory floor looks okay, actually. It's a modern factory. But when you go behind the scene, all these workers working on these production lines are immigrant workers, typically from Nepal and Bangladesh, sometimes from Indonesia or a few other countries. And the problem is that they've paid large recruitment fees for this opportunity to come and work here, and they think that everything's going to be fantastic. The realities are that they often are paid a very low wage. They will often work very long hours. and have deductions for things such as food and accommodation, which is provided by the factory. But the accommodation is not what you might want to see. So this is another glove manufacturer called Brightway, which was again supplying all over the world, certainly supplying to the UK. And this is probably the worst accommodation I've seen, but there is bad accommodation throughout the sector. So these workers were living in shipping containers inside Malaysia. So their entire existence was between living in these shipping containers and working in the factory. Their passports were confiscated, so they were not able to go anywhere else in Malaysia. And for years, this is their entire existence, making these gloves for us to use in our healthcare settings. We've surveyed 1,500 workers, and the data we found is that over 40% of workers are taken out alone, as I say, to pay their recruitment fees. So it's not easy for them to pay these illegal recruitment fees, and some of them had sold land for this golden opportunity. Half of them then felt unable to leave their employment because they paid these large recruitment fees. But what we found is they were working typically 12 hours a day, and 1 in 10 had not received a day off at all in the last 3 months, and 1 in 3 had had just 1 day off per month. So this is difficult work, and mental health issues are not unusual. And I'd like to tell you it's just these 2 factories, but actually this is an endemic problem. And all these other glove manufacturers in Malaysia have got the same problem with forced labor of migrant workers and illegal recruitment fees. Some work has been done, and some of these companies have now improved their practices, not least because the US banned several of these suppliers because what they were doing was illegal. So some of the factories, such as Top Glove, things are now much better. We think that this labor rights issue is probably widespread as well. We've got some data. It's very difficult to know where your products come from, but we've got some data from Norway and from Cambridge hospitals in the UK, where we tried to find out where products were coming from. In quite a lot of cases, we had no idea where the products were coming from because that information was not available. But overall, we found about half of all our medical products are coming from countries with very high risks of labor rights abuses. So is reuse the answer, and why is it the answer? You've already heard that this is the linear economy is no good for our planet. It's not surprising, but let's quantify that. So we've done some data looking at single-use scissors, for example, and we found that the carbon footprint of reusable ones is is more than 10-fold less. And that's taking account of if you have to sterilize and clean it and transport it there and back, you're still much, much better reusing these products. And there's a systematic review of 22 studies, which finds exactly the same, that as a general rule, reusable equipment is much, much better for the planet and often saves money as well. So why have we moved to this? Why is everything disposable is a real question. So I think it comes down to at the point of use where you're actually using the equipment, there may be perceived or uncertain risk of infection in particular is the thing that people are worried about. But it is a perception often rather than reality. But also it's convenient. It's much easier to just use something and throw it away rather than have to worry about either cleaning it, reprocessing it, and bringing it back into the system. So we need the infrastructure to enable that change. And there are system challenges. So, for example, in Europe, there are regulatory challenges that say regulate when a product can be made reusable. And some may see that as a challenge. And there may be financial structures, as I mentioned, that support a linear economy. So our models of purchasing are built on annual contracts and volume. So we buy, and we buy within a year to make our annual cycles meet, which also promotes a linear economy of continual consumption rather than investment for the longer term and a real discussion with our suppliers of that investment. But also, we also find that there's a lack of guidance on infection risk. And so individual organizations will decide their own policies on infection risk, which again promotes this throwaway culture. And I'm going to come on to some of those misconceptions, that lack of guidance, I think, that leads to this throwaway culture. First of all, you're probably going to hear about this later on from gloves. Gloves is the single biggest source of single-use plastic in most health institutions. Certainly where I work, it is. And in the NHS in England, prior to the pandemic, we were using 1.7 billion gloves every single year. I've worked out if we put those end to end, it would almost stretch to the moon. That is a huge amount of single-use plastic, and that's just in one country. But we also know from data in the UK that most glove use in the UK is inappropriate. 2/3 of gloves should not be worn. They're put on because people have misconceptions about what gloves are for. And really, we're trying to work to say that gloves are only required when there is expected contact with potentially infected bodily fluids or broken skin. There will be a video released from NHS England, hopefully by the end of the year, but if not early next year, that is a short animation trying to educate people on when they need to wear gloves so that we can stop this pandemic of plastic use. And inappropriate use may be perpetuated by individuals. As I say, many people will just put them on incorrectly. In hospitals as well, we see infection control teams telling people to put on gloves when they're absolutely not indicated, and that is a lack of knowledge on their part. And even government. I've written to our government to ask them why we were all told to put on gloves during the COVID pandemic for what is a respiratory virus. We should have been all washing our hands. There's other institutional misconceptions. So, for example, the British Orthopaedic Association states that drapes and gowns must be made of impervious materials. Thin cotton drapes and gowns have no place in orthopedic surgery. The way that this is interpreted now across the orthopedic community is that we must use single-use plastic drapes and gowns, and we cannot reuse any drapes and gowns. And that has a significant carbon impact. So when we looked at our data from 2 operations, you can see that the carbon footprint of using single use is quite a lot. 72 miles driving in an average UK car, that would be around 140 kilometers, 130 kilometers. And similar for carpal tunnel decompression, 21 miles, which is around 40 kilometers in an average UK car. And that's for one operation. You can see how many are done across the UK each year. So these surgical textiles is a misconception. Yes, single use is typically non-woven plastic petrochemicals made overseas. Reusable are the same high-density petrochemicals, sometimes made overseas, sometimes made in the UK, but they are reused typically 75 times. And the idea we shouldn't be using cotton, I completely agree with. Cotton has not been used across Europe for more than 20 years because it does not meet standards. So why is this misconception perpetuating? And reusable textiles, we know, have typically less than 1/3 the carbon of disposable throughout their life cycle. So what I try and tell people, all health textiles must meet these standards of a liquid penetration and microbial penetration throughout their life cycle. There is no concern of real increased risk of infection. And actually the reusable textiles, unsurprisingly, are much better because they are better made, they are higher density textiles, and they have better strength and burst. So if you're worried about infection, it is actually the reusable textile that you should be using, not this single-use, lower quality product. And actually, in the UK, we have the enabling infrastructure. So this is bizarre. We have laundering facilities, we have sterilization facilities, we have very high standards for laundry cleaning and sterilization in the UK. And so it is simply using that infrastructure. I know that other countries, unfortunately, don't have this infrastructure, and that is a challenge to your health systems. You need to build this infrastructure to allow these gowns and drapes to be reused, and because some countries simply don't have that, so your linear economy will continue if you don't produce the solution. There are other institutional misconceptions. For example, this is some data on ear microsuction, where some people will just change the sucker, which has a plastic component, but others will change the entire tubing that's used after each procedure, and some will change the actual suction canister. This is absolutely madness. Wax is an oil. We would not throw away other things after they've been in contact with oil. Otherwise, we throw away most of our food that we fry. It's an oil. There's no known risk of infection from an oil. It seems reasonable to throw away the sucker. but why do we need to throw away other things? And if you take the high carbon approach, where you're throwing everything away, it has an 85-fold increase in the carbon as well as the amount of plastics that's used. And people put on gloves for this as well. Again, completely unnecessary. So it goes beyond that. We have single-use tourniquets made of plastics. We have single-use blood pressure cuffs. In the USA, we have single-use pulse oximeters, plastic and chips that are designed to measure oxygen levels, and you throw them away because somebody might die. I just really don't understand it. And if that's what you're going to say, then I say we need to have single-use door handles, because if you look at the door handles in hospitals, they are covered in bacteria and potentially infected. And so we have to remove the door handles. We have to throw them away and replace them every time. Or perhaps maybe we just wash our hands before and after patient contact. In terms of regulatory restrictions, in the UK, for example, tracheostomy tube, something put to help people breathe who can't breathe through their normal mechanism, they have to be replaced after 28 days because otherwise they're classified as an indwelling device. Of course, there's nothing that happens at 28 days where it suddenly becomes an infection risk. It could just be cleaned and washed and put back in, as it has done for the previous 28 days. And I'm afraid the industry is also quite happy to promote this idea. So here's some endoscopes. Endoscopes, unfortunately, in some areas have become single use as well. This is something to look inside someone's nose. It contains a chip, it contains plastics, it contains microfibers of optic fibers. Cheap, of course, now because electronics are cheap, we can just continue to extract from our planet whatever we want. And so there's a paper suggesting that we should eliminate the serious potential risk of prion transmission. This study, I think, was funded by the industry, but the Department of Health in the UK says there is no known risk of any serious prion disease, that's CJD, being transmitted by surgical instruments or endoscopes, ever. So this is simply misconception or perhaps lies. And I'm afraid we also see this with other products. Here's a product, an electrosurgical product designed to actually coagulate blood vessels, and it's £500. It coagulates in blood vessels, and then you throw it away. But we know that it can be reprocessed because some people do. You change the tips there, and you have to open this body, and inside there's a chip. You have to take the chip out because the chip is programmed to be used only for a few hours, and then it can never be used again. So this is planned obsoletism. It's planned to be thrown away. They replace the chip to allow it to be reused. But the body is made of single-use plastic, and eventually that fails because you can only sterilize that a few times. It needed to be made of metal, and it needed to be made to last for a long, long time. So I'm going to finish soon, but here's some parallels. This is one of my real hates. Across many high-income countries, we have perfectly clean tap water, yet we see a huge expansion of bottled water. Packaged in petrochemicals and transported. It costs more. Of course, tap water is free. No assurance of the contents. People seem to think that bottled water is healthy. Absolute nonsense. It can contain all sorts of nasty chemicals, including arsenic. For example, this brand, Fiji water, the water comes through the Fijian mountains, which are covered with arsenic, and the arsenic levels have been found much higher than will be allowed, certainly in UK tap water. And it contains chemicals such as DEHP, plasticizers that are linked to endocrine disturbance. You won't find that in your tap water, but you can sell this to people. And in the UK, where we have perfectly clean tap water, unfortunately, 1.5 billion is spent on bottled water. So looking forward, we don't need to carbon footprint everything before we act. We need to move to the circular economy. Recycling is not the only answer. It's a very small part of the answer. We don't need companies doing tokenistic greenwashing, such as putting solar panels on their factories to make disposable plastic products. We need them to make products designed to last, and that should be our challenge to them. We have a Green Theatre checklist that was launched actually just a few weeks ago. And that is a guideline. It's actually badged by all the surgical colleges in the UK that gives examples. That includes some things about reducing plastic use and moving to the circular economy. So this is guidelines that hopefully will be internationally adopted, and you can find those free online. And going forward, I'm producing a national report on what sustainability in surgery looks like, and we're doing some academic analysis to try and create this circular economy for medical products. Thank you for your time.
Thanks a lot, Mahmoud. Thank you very much for this great presentation. We might have time for a couple of questions, so I might not be able to ask all of them, but maybe one from James. Challenging ourselves to reduce and refuse single-use consumables is an important step, but how do you map into the discussion clinical, economic, and provider outcome benefits of single-use versus reusables?
So I think we need to challenge the prevalence of that single use is potentially protecting patients. I think I've shown you multiple examples of where that's simply not true. If you've got good sterilization and cleaning services, there is no risk to patients. It's all theoretical often. I mean, not always, of course. We can't reuse plastic cannulas that goes in to take someone's blood or to provide drugs. Those are just difficult to clean and probably easiest to just throw those away. But for many of the other products, we need to actually challenge. So we probably need national level guidance for everybody to say, that's not an infection risk. Just carry on. You either need to just continue to use it, clean it and use it, or sterilize and reuse it. So that's probably where we need to get through. The economic models are up to hospitals themselves, but you're normally going to save money. I'll give you an example. Our tourniquets were single use in my hospital, single use plastic, and we challenged it, and our infection control team is very supportive. They said, just wipe them down and reuse them, and that will be fine. We are going to save 5.5 tons of plastic every single year in my organization alone, and we're going to save £87,000. So that will certainly get your health systems interested.
And I mean, I think you said something that was really key here. You said that the infection prevention and control team was supportive. So what can be done when the infection prevention and control team is not as supportive, or they're really advocating for everything single use?
So I think that's the biggest challenge. And I think what we need is national guidance, and hopefully will be internationally adopted to say, this is the way forward. And I'm working on that. I'm working with the professor of infection control, because it's tiring to have to fight these fights at every single institution. So we need to change our ideas of what is best practice. Best practice includes not harming our planet, and it doesn't include compromising patient safety. So I never say that I'm going to in any way compromise patient safety. The two things are not incompatible. And in fact, as I've shown with some things such as textiles, I would argue, if you're worried about infection, why are you using single-use textiles if you've got sterilization facilities available? Certainly in the UK, that is available, and the textiles are much higher quality. And so if you're worried about infection, you should not be using single-use textiles. So I think we need to change the narrative on this. And I don't have an easy answer, but I can promise you I'm working on this. And I guess as we start to develop this, please try to look at some of the guidance. So the Green Theatre checklist is the first thing. You can take that to your infection control team. What I've also done is, where you do find that infection control teams are being resistant, I sometimes write an email and ask them to explain why. And often you'll find they won't be able to explain why. But I would send it in an email, because people have to actually write down, and then you say, okay, I'm sorry, I'm going to change to the reusable equivalent unless you can give me the evidence for what your decision is. And if you've got guidance from elsewhere, then that's also good. I think one of the biggest things you can do to start with is challenge the glove use culture. Glove use is just the pandemic, and we know that it's all based upon misconception often.
That is great. I mean, we will have the presentation afterwards to try to challenge this gloves use culture. We actually have a lot of questions, so I will maybe ask one or two more, because we also don't have a lot of time. But Karen asked, as a first step, do we attack the highest use areas like operating theaters, or go for non-clinical or outpatient areas to build momentum before going to places like operating theaters?
I think the question is, what's the easiest win in your organization? So I think gloves is across the scale, and you're going to hear about that. I mean, Great Ormond Street, you're going to hear from, is the classic example of that, where they have done a great amount of work on that Great Ormond Street Hospital in the UK. I think if there are other easy things, such as you have in your country, the ability to reuse gowns and drapes, because that infrastructure is there, then that should be enabled straight away as well, because that's already available to you. If the infrastructure isn't available, that's going to take more time. I think you can also involve the operating theatre, because there may be single-use products that can be made reusable. So, for example, it's quite common for little dishes to be made of single-use plastic that you might use to have water during an operating theatre. There are metal versions of those available. You can just put them inside the tray where you're sterilising all the instruments, and there you go. You're going to save money because the sterilisation costs the same, and it's exactly the same quality of product. So I have no idea why we are using single use. So I think it's a case of understanding the volume, but also understanding where the easiest changes are, because once you start to make the changes, people will see that, and then it starts the conversation to make the more difficult changes.
And what would you say are some low-hanging fruits? This is a question from Maurizio.
Yeah. So I guess it comes back to what I've just said, which is it depends on your organization.
Yeah.
I think gloves is the obvious one. I think textiles, if you have the infrastructure already there, are the two low-hanging fruits, I would say. And I think changing products from where there is a reusable equivalent available, such as a kidney dish in an operating set. So, yeah.
Thank you so much. We still have many questions, but we do have to move on with the next speakers. But if you have the time to still stay a few minutes, if you want to answer some of the questions in written form in the Q&A, that would be great. But it's great to see that there is a lot of interest in the topic that you presented. And again, thanks a lot for the presentation. So now we will hear about one of the areas where there's a lot of potential to reduce plastic use, which is gloves use. And we will hear from Nicola Wilson from Great Ormond Street Hospital about their great project on reducing unnecessary gloves. Nicola, the floor is yours.
Thanks, Andrea. Hi there, everybody. Yeah, I'm just going to share screen with you. Bear with me one moment. And hopefully you should be able to see that. Andrea, can you see that okay?
Yes.
Perfect, that's brilliant. So I'm Nicola Wilson. I'm a practice educator at Great Ormond Street Hospital. And in 2017, really, so it's a long, long time ago for us, we started this project at Great Ormond Street, and it was myself, the infection control lead, Helen Dunn. So I can completely appreciate that not all infection control leads are as supportive as her, but she definitely is. And another educator, Amy Leonard. And we undertook this, and I'm going to talk you through what we did and how we were successful. So we launched, although we started working on it and sort of unpicking the different bits in the background, we launched it across the trust back in April 2018. And I'm going to take you through what we did with that, and what our sort of key factors and driving forces were within that, and how we went about the change. And our progress so far and our bumps along the road, I suppose. So why on earth did we start looking at glove use? So we knew that it was really closely linked to hand hygiene. Back in 2017, we changed the way we audited our hand hygiene in the hospital. We had previously just been collecting quantitative data, were hands washed or decontaminated using alcohol gel at certain points at our 5 moments of hand hygiene. And it was sort of a tally chart more than anything else. And so what we did is we changed to collecting qualitative data. If someone's missed a moment, why have they missed a moment for hand hygiene? And we got our wards to go and audit each other's wards for more useful information. And when we brought the staff back and said, just tell us what you saw out there, the residing factor for why people had missed a moment of hand hygiene was because they were still wearing gloves. They were touching the door handles, they were answering telephones, all sorts of things, but still wearing those gloves. So we really questioned, why did you have the gloves on in the first place? We also knew that a number of our staff were getting really sore red hands, particularly the nursing staff, drawing up many intravenous drugs throughout a shift, washing their hands, putting them in gloves, washing and drying their hands, putting them in gloves, actually class them as wet workers, and you'd see their hands becoming really red raw. Helen had recently returned from a secondment with the RCN, where she'd updated some national guidance on the use of gloves. So that very much helped us. And we also did a skills standardisation study day for our educators across the trust to really question, are we teaching things the most up-to-date way and in a standard way across the trust? And in that, Helen really challenged us to say, why are you using gloves? And it was the first time kind of as a group of practitioners that we had kind of even questioned that use. We'd always thought it was infection control that had wanted us to use gloves. So hence us sort of unpicking it and asking the question. When we looked at the research, it mirrored what we were starting to think already. So we now know that if you're wearing gloves to protect your patient, it shouldn't be non-sterile gloves. It should be sterile gloves if you're using to protect your patients, because actually non-sterile gloves can be contaminated with a range of bacteria. And we all see them, don't we, on the boxes, on the walls, sort of sat there for however long, just collecting dust. And so really question, why should I, and what are the occasions I should put on non-sterile gloves? And Mahmood rightly says, it's when you're in contact with bodily fluids or a mucous membrane. So we really needed to reinstill that across our trust. And then the research by Wilson, and not me, Wilson, another Wilson, and Loveday really reiterated what we'd already found in our audits as well, to say that the use of non-sterile gloves was really associated with cross-contamination and transmission of hospital-acquired infections, because they're worn at moments where they really aren't needed, and what we should be doing is good hand hygiene. This research that they did at the bottom here was actually amongst adults, so I'd love to see it replicated amongst children. But that feeling that if someone, a nurse or a healthcare support worker, cares for you wearing gloves, actually we are making our patients feel uncomfortable. So we need to be cautious in that as well. So we asked our staff, we trained them, our educators, for mostly probably February to March, and then we asked them from a March to April to go out and train across the trust. And we really asked for these key changes. The first one, please risk assess when you're using gloves and aprons. Don't just automatically put them on. What we really wanted to do was empower our staff to realise you're intelligent. You make the judgment. You know if you're going to come into contact with bodily fluid or a mucous membrane. And then really particularly around our drug and IV administration, and to say, please don't use gloves. We did have some exceptions. We still wear gloves when giving chemotherapy, for instance, or a cream that might be designed to be absorbed through the skin. We would ask staff to put on gloves in those moments, but not for routine antibiotics and things like that. If you spill a drug and get it on your hands, wash your hands. It was our kind of very clear message that came through. At the time, because it was us three making this big change and very apprehensive of what we were asking, we knew that the research was there. We knew the logic about why we were doing this change. But we were possibly a little too cautious, and we didn't want to make that change where there was infection precautions for our patients at the time. So we did that as a second step change later on. But now I'm really pleased to say that that second step change has equally worked, and we see hospitals taking this on as a whole change. So what did we do? We were really, really clear about our aims and empowering staff to make that decision. We had a working group across the trust of people that we thought would challenge us the most. Who were going to be the people that go, oh, that will never work? So we asked them, we brought them together, and actually what we found from those staff was they wanted us to go further. So where we're talking about IV administration, they started to talk about the dressings for our central lines and how we change those. We asked the trust, obviously, to buy in. So we took our change to various different committees to be challenged at the time. We updated our guidance, and we talked about the common strategy with our communication team. And that was really interesting, because where we thought we would have to educate our patients and their parents about our change, they actually said, no, if you highlight this change and that you're going to do it from one shift to the next, then they're going to be asking, why haven't you done this earlier? And actually what you want to do is empower your staff to be able to answer those questions when needed. And so that training that we did was across the whole trust, so not just nurses, healthcare support workers, medics, but your porters, your cleaners, your housekeepers. You have to include everybody within this. So we went all across the trust with this change. We had a range of resources to match it, whether they be PowerPoint presentations, discussions with staff, like I say, teaching across all sorts of groups of staff. We had frequently asked questions of things that would come up, and we even did screensavers of the computers across the trust. And we launched on the sort of hand hygiene day. We did a sort of follow-up event as well. So what happened? These are our initial sort of data, and you can see from these charts, the green line is our sort of average change, whereas the blue is our literal what gloves arrived within the trust at any given point in time. So the green is that average, and you can see that we've got some spikes. Now those spikes tend to go alongside when we had a new opening of a new hospital building, and our procurement team would buy more gloves in preparation for that new opening. So we've got two very clear spikes there on the charts, but you can see here that drop, that significant change where we first introduced our project, and then we had a new baseline, and then our second change when we introduced the next step as well. So a massive change in our glove use across the trust. And this is what we kind of broke it down to. And I'm sure if I did it now, I'd work out the embodied carbon of those gloves and all sorts of other metrics, because I think we're thankfully as a healthcare organisation a lot more knowledgeable about this now. But at the time, we looked simply at the number of gloves ordered, the cost of those gloves, and the cost as well of the disposal of those gloves. And we've got a little asterisk there, because actually we were still making savings in the disposal of gloves, despite the fact that the cost to dispose of them had increased nationally. So we were still making savings. And this is where a key point came across. Initially, we had started this project because we knew it would be better for our patients. And actually, the sustained nature of this project was because our healthcare workers are so fascinated and so on board with the savings of plastics. And so this helps propel the change and embed it into practice. But also financially, when you talk to the exec team and you talk money, you suddenly get a lot more backing. And then from our staff's perspective, on the left-hand side here, you can see the hands of our lovely Katie Lord, one of our nurses who had really chapped and red hands before the change. Those two photos are before the change. And when she described that actually after a 12-hour shift, going home and getting into a hot shower was actually painful to her hands because they were so sore. And 12 months later, these were her hands, absolutely brilliantly in good condition, because she's not putting them into those gloves as often. And infection control, what we did see is that people were decontaminating their hands far more appropriately, as we had hoped. So it was working from an infection control perspective, and we didn't see what we were obviously worried about. We didn't see any change in our hospital-acquired infections that could be linked to this project at all. So that was our second change here that I'm showing on screen, is when we asked people to do exactly the same in isolation precautions, which Mahmood rightly said, you know, why did we then change to wearing gloves during the first stage of the pandemic? Because that was a respiratory virus. So we had already made that change. Unfortunately, obviously during COVID, we had to mirror and what the government was telling us to do. So what you will see here is our massive spike in glove usage and ordering there, and that's around the government suddenly telling us that we needed to wear gloves. And also our data then becomes a little bit harder to track, because we had a national procurement of our PPE, and we were no longer as the trust allowed to order our own PPE. That was done nationally. So a big change there. But what we did find through COVID is, as soon as the government kind of caught up with our infection control guidance and we were able to go back to our own guidance, that our staff really returned to our baseline quite quickly. Because they'd already had it so well embedded and they understood why they were doing it. They knew the background to it. And then I finally just wanted to share another project that we are undergoing in this trust with a fabulous occupational therapist called Jacqueline Gordon. And we're really starting to look at other things like reusable sanitary products. I think, you know, we have so many young people in this trust looking at this from their own perspective. When you have say a new hemiplegia or something and you can't use traditional products that we now see, you know, your Tampax and your sanitary towels and things like that, and so really encouraging people to use reusable products, whether they're period pants or reusable sanitary towels, because they are so much better for our children that have disabilities. They're so much financially more viable in these times when we're finding an increased cost of living, and also we're seeing a lot less plastics being used. So this is a poster, and I'm sure when the slides are shared or they're on the website, you can have a look at this and ask any questions. So I just wanted to introduce that we are doing, and this is just one example of other projects that you'll see at Great Ormond Street. Thank you. I hope I wasn't too fast for the interpreters. I'm so sorry if I was.
I think it was all right. Thanks so much, Nicola. It is always great to hear about this amazing project. It is such a concrete action that generated concrete results. It is awesome. If you have any questions for Nicola, do ask them in the Q&A box. For now, we will move on with the next presentation and we'll handle all the questions at the end. So next we will hear from Federica, and
hello.
She will talk about her efforts of reducing plastics in her practice.
Hello everyone, and thank you for having me here. I'm just gonna share my screen and present myself briefly. So Federica is my name, and I am an anesthetic nurse. I lived and worked in Dublin in Ireland for about 6 years, and just recently I moved back to my own country in Italy. And the reason why I have been working on sustainability in the last few years is both because I am a mom and both because I am a nurse. So as a mom, I'm really worried about my kids' future and what kind of world they're going to live in. And as a nurse, I am really worried about the effect the climate change is going to have on human health, and how this is all going to impact our work as a healthcare professional. So in 2020, I joined the Green and Sustainability Committee in my hospital as a theater representative. And in about 2 years, we were able to realize a few sustainable quality initiatives, few projects, and I'm going to present to you 2 of those today. So Mahmoud already explained about the healthcare environmental impact and especially the theater department. So I think I can just move on from this one. And the problem is that even though awareness is increasing about all this data and how much impactful we are with our job, I think there is still a huge gap between what's the theory and what's the practice. So you go in your own department and you just have to fight every day with between your family life, working balance, and massive workload, shortage of staff, shortage of resources. And it seems really difficult to find the place and the ability to introduce something new and to challenge yourself and your colleague with something new. But it is actually possible, and even every small little step counts, I believe. So I'm just going to present here two of the projects that we were able to realize in my department. Both of the projects are related to waste reduction strategy, and also they are 100% nurse-led projects. So they can hopefully be an example of what nurses can do if they put their forces together. So as Andrea already introduced, when you talk about waste reduction also in theater, usually people think about recycling. And unfortunately, we know recycling is not that effective. And it's really hard, especially in the theater sector, to implement recycling anyway, because there is a lot of concerns about infection control, and it takes a lot of time, it takes a lot of effort, and is not that powerful. So we should really move on to other projects. What you should do, and actually will be more effective, is try to prevent the amount of waste we are producing in the first place, as Andrea explained already. So for example, in my department, as an aesthetic team, we realized that we were using a lot of pre-made disposable sets. So we had pre-made sets almost for anything, preparing for the arterial line, for a central line, for the spinal anesthesia, for preparing patients for cardiac surgery. Everything we were doing, we were basically using a pre-made sets. And all of those sets were containing unnecessary material. So the second we were opening the set, we were just throwing what we didn't need in the bin without never using them. And of course, the manufacturing, the transportation, the disposing of all this unnecessary material has an effect, and it results in needless greenhouse gas emissions, waste generation, and also financial costs for the hospital. So as a team, what we decided to do, we decided to try to change two of those sets that we realized they were the most wasteful. So the set where we were using for the spinal anesthesia, and the cardiac set that we were using for preparing patients for cardiac surgery. And so we implemented this project that was divided into 4 phases. So the first thing we did, we include our stakeholders that in our scenario were the consultant anesthetist and the anesthetic sister. And we explained them where as a team, we wanted to remake the sets in order to make them more environmentally sustainable. And all together, we redesigned the set, deciding what we wanted to keep, we could get rid of. And once we found a common agreement on how the sets were supposed to be, me and the anesthetic sister, we contacted the suppliers and we explained them the projects and told them that we wanted sets to be remade as a custom pack in order to make them more sustainable. And after that, we organized an education session for the staff. So we invited everybody from the managers to the housekeeping, the healthcare workers, nurses, doctors, everybody who wanted to join was invited. And for a week, we had 10 minutes presentation in the morning before starting our list on sustainability, climate change, waste reduction strategy. So we did a little bit of education, and it was a great chance to talk about something that we usually don't have a time to talk about, and we are not usually thought of in our nursing curriculum. And after this, I tried to calculate the financial and the environmental saving of the projects, if there were any. So it took about a year time for the new sets to come in production. So the implementation was quite slow. We had some challenges because of COVID and some delays because of a shortage of staff as well in the suppliers company. So it was a little bit of a slow implementation. But after a year, the new sets were available, and those are the data I was able to calculate. So it is not necessary to be an expert to try to calculate financial or environmental savings of a project you are trying to make. because that requires a lot of time and skills that nurses usually, at least myself, I don't have. But there is a lot of tools available that helps you try to calculate carbon footprinting in the healthcare sector. And it's, even though these data may not be as precise as life cycle assessment, they are useful because give you an idea and give you a feedback and give you an idea of the impact that the projects you're doing is having. So I really suggest people if you're interested in this kind of research, to try to look at some internet tools. So I estimated that by switching from the old sets to the new sets and just getting rid of things that we actually don't need, that we were not using, the department was going to save about almost 4,000 kilos of carbon emissions every year, and about 430 kilos of waste every year. And then estimated about 10,000 euro of saving every year for the procurement and incineration. And also it was a great chance for staff education. And also we got a great feedback for everybody who was involved in the project. So we were coming off, that was done in 2021, we were coming off COVID time, and everybody was really tired, depressed, and participating in this project was really a great chance to do something new, and everybody really got on board with it, and they were really happy with the project. So it was a great success. And so we were so happy that after this first project, we decided to realize another one. And I'm going to present you the second project as well. And as Andrea said, after preventing the first the waste you're producing in the first place, the second most important action you can do is try to switch from single-use items to reusable. So Mahmoud presented this very well as well. So in theater, like in the rest of the healthcare sector, we are basically using this linear economy model where we buy a lot of single-use items, they come to us, we store them, we use them once, and then we dispose of them. And mostly there is two big reasons for this. First of all, because it's believed to be safer as an infection control point of view, and we already saw with Mahmoud's presentation that's not really the case, and the data are actually really confusing. There is no clear literature, and there is a lot of guidelines and regulations and clarity about this matter. And the other reason why we use a lot of single-use items is because, of course, this maximizes profits for the suppliers because they sell high volume of items, and it's also actually convenient for the hospital because you just minimize liability, you use the item, you dispose of it, and you just forget about it. You don't have to worry about reprocessing, sterilization, human error during the process. So it has been convenient also for hospital to use this kind of approach. But since COVID, then in the last few years has been kind of clear that this model is not sustainable, not just in healthcare, but in every human sector. And we know the prices are increasing, so the purchasing is really unsustainable also financially, and we are experiencing consumption disruption in the supply chain basically every day. So something needs to be done, and we need to really advocate for bringing a more circular economy model also in healthcare, because that can provide a more sustainable and financially and environmentally, and also more resilient model of buying and purchasing also in the healthcare sector. So in Ireland, it has been regulated in 2021 that it's possible to reprocess single-use medical devices. So this Article 17 of the Medical Devices Regulations approved in May 2021 the reprocessing of medical devices. So it is possible now to reprocess medical devices in Ireland. So I was looking into it, and I was having really a very hard time to try to find a product that we could reprocess or make reusable instead of single use. when I got really lucky and I got contacted by the rep in Ireland of a company, of a leading company in Europe about reprocessing medical devices. And he saw a presentation I did in the Clean Med conference in 2021. So he contacted me and we had a very nice chat. I know he's here today in the audience, so I just want to thank him for contacting me today. And we had a nice chat, and we realized that in our department, we were actually using one product that this company was reprocessing, and that's the ultrasonic shears that are used for laparoscopic, gynecological, and general surgery. And so this was an item we could start with to introduce some circular economy and remanufacturing in our own department. So again, we set up a project. The project was divided into 3 phases, 3 parts. So the first thing we did, we had a meeting between me, the rep of the company, and then we invited also the CNM of the general and gynecological surgery, the CNM3 of the department, the chief of procurement in the hospital, and then initially infection control was involved as well. They realized there was no need for them to be present because there was no infection control issue with the project. So after we set up the meeting, we assessed the availability and of the hospital to go ahead with the project. And then once we got the agreement from everybody, we started with the second part that was a little bit more practical. So we established a new circular pathway for this item, and then we educated the staff from the general and the gynecological surgery staff on how to start the project. So basically what we did was explain in this little graphic here. So in the past, we would have purchased the new device from the company, store the item, use it once, and then dispose of it. With the new project, with this remanufacturing company coming along, we changed the pathway into a circular model. So we are still at the hospital buying the new items from the original company, but instead of using it once and then just throw it away, we are collecting the items in different special bins that have been provided by the remanufacturing company. And then they come once in a while, they collect all the items we have been used, and then they reprocess them and they mark them with their own brand name, and they are marked as CE products. So there is a full traceability, labeling, everything is guaranteed from the CE mark, and all the products they produce are checked for safety, performance, conformity. They are as good as new ones. And then they resell these items to hospitals. So the hospital can either buy back the item by paying half of the price rather than buying a new one, or the hospital, they can just decide to sell the items he's using, and then the items are sold to different hospitals. So that's what we did. We decided to do. The managers decided in the first place just to collect the shears we were using, could give them to the reprocessing company, and then the reprocessing company is selling them to other hospitals. For at the moment, we are not buying them back, but hopefully that will come. And once we established this new circle, we decided to assess the project for 3 months and see how it was going, collect some feedback, and then decided if we wanted to go ahead or not. And after a few months, actually, we had great results and great feedback. So in a few months, we were already able to collect 24 of these electronic shears. For each one of those, the hospital was paid €8 for collecting them instead of throwing them away. And the hospital was also saving money by not disposing of this in the landfill or incineration waste. I roughly calculated that we already saved about 20 kilos of carbon emission and 20 kilos of waste by reprocessing in 24 hours. And for the staff of the hospital, has been really a really easy implementation of the project, because there is a minimal storage space required. We just need to collect the items in a separate bin that is kept in our exit room in the theater. There is no further workload for the staff. The items just need to be wiped after being used and put in a plastic bag and then put in this special container, and that's it. And there is no work for the CDU, for the sterilization department. All the collection and the transportation of the items is organized by the supplier, so there is absolutely no any effort that is required from the hospital. So the implementation of the project has been really, really easy, and everybody was really happy with it. And also, we already found there is a possibility for expanding the market. So I no longer work there, but I know they are talking about collecting other items like ligatures. There is a lot that can be done in the cath lab as well. So it's really moving and improving market. So it's been really, really a good project so far, and we are really happy to go ahead with it. So I just want to say that if you are interested in sustainability and you want to do something about it, you just can start with small steps, small sustainable steps. Try to involve your management, because there is a lot of people who are actually really prone and keen to do something. You just need one person to start, and just try to inform yourself as much as you can, inform your colleague, and try to advocate for change to come into your department as well, and be your own change. That's it. I hope it was clear. Thank you.
Thanks a lot, Federica. That was really inspiring to see how you did this work. So it's great. So if it's okay for everyone, if we stay like maybe 5 minutes more to answer some of the questions, sorry for that. Before we start with the questions, just to let the participants know that we have our second webinar next week on 7 December at 4, and we will focus here on plastics, chemicals, and health. So you can register to that as well if you want to. Now to move to the questions. I will start with a question for Nicola. So what would you say, Nicola, that is the biggest challenge in reducing the use of gloves?
I actually think that the biggest challenge for us was something that we weren't expecting. So, and it probably normally is. It wasn't from the people that we thought would challenge us. It was actually about the way we approached it. There were some areas within the trust that were a little more reluctant or slower to uptake the change than others. And that was often because maybe their educator or their ward manager had shared the teaching just by forwarding an email and the PowerPoint in an email. And that is no great way or method of communication. The best way that these changes were made were predominantly with the intravenous administration practice, was when the educators did an update with every member of staff as a one-to-one. We updated their clinical practice, and then that helped challenge and challenge their muscle memory in when they normally would just automatically put on gloves. So it really is, I think, about that communication technique that you use, and kind of really challenging people at the moment that they would normally use those gloves, because you can know everything you want to know about the change, but until you actually remember it physically, you don't do it.
That is really great to know, especially because we have a lot of our members that are really interested in replicating this project. And yes, I think it's useful to know what are the most effective ways of actually having these behaviors adopted. We have another question for you from Clive. He is asking, as a clinical user, do you have any say in the purchasing supply chain, like what we saw in Professor Butta's concern over the poor standards of work?
Yeah, I think there's probably a few answers to that. So the first is we had limited, because of COVID, ability to affect any of our PPE. That became quite nationalised. And that is changing and becoming far more localised. Me, from a personal level, I'm very lucky. Our procurement team are at hand, and they do answer loads of my questions. And so I can ask, what's the volume of something that we use in the trust? What's it currently cost? What's it made from? Where does it come from? But I suppose one of the challenges is, how much do I know about the workers' rights within a certain country? And am I as knowledgeable, or do I need to learn a lot more to get there, so that my challenge is right? But what we are having across the NHS now is that we're being asked to have a 10% weighting towards environmental and social concerns when we have procurement of goods. So that is being looked at an awful lot more by our procurement teams.
Thanks. Thanks a lot. I will now move to a question for Federica. You talked about having some delays in the changes for the pre-made sets. Was this due to the current contracts, like a difficulty to make changes? This is a question from Melanie.
No, it was a very specific case, I think, because I was expecting, for example, from the suppliers a lot of resistance, because of course the sets were going to be smaller, they were going to be cheaper. So I was expecting them to be a bit more, challenging. Instead, they really came on board with the project. They have sustainable standards that now they have to respect as well. So one of the companies sent me back like 200 pages of sustainability effort they were doing in their company. So they really came on board with it. But we really had the practical delays because they were having, of course, shortage of staff because of COVID. We were having shortage of staff because of COVID. So I was trying to deal with the project while working full time as an aesthetic nurse. So that really took a little bit longer. And then we had a delay in one of the sets because it was made wrong the first time. So they had to redo it and re-go through all the process for actually make it right. So it was really just technical details, but I didn't find any, to be honest, I was really surprised. I didn't find any difficulties by talking with the anesthetists. I didn't find any difficulties from the suppliers. So that was really encouraging. And as I said, basically everybody was thinking about these sets were absolutely crazy, they were absolutely wasteful, and nobody was just saying anything. So they just needed one person to start the conversation. So it was really due to COVID situation and practical difficulties. So it will be nice to have dedicated time to bring these kind of projects, follow these projects through. Yeah, that should be contemplated. Yeah.
Yeah, this is a huge issue on the problem of pre-made sets and also on the problem of time that you just mentioned now. So how did you actually get in touch with the suppliers? Was it something that was easy for you to do as a nurse?
Yeah, I just called them.
Okay.
I just called them and sent them an email, and after checking with my manager, of course, and then we just explained the situation, and we told them we wanted to remake the sets in order to make them more sustainable, and then we just move on with emails and be sure that everything was written, was really clear, and nothing else. Yeah, it was quite easy, to be honest. I wasn't expecting that to be that easy.
Yeah, I'm glad that it was this easy, and maybe more people who participated will be inspired to call their suppliers and reduce the items in their custom pack.
Yeah, it can be done. And absolutely, there is, as Dr. Gutta was saying as well, there is absolutely no impact on the patient safety, on the patient quality care. This was just material we were not using and just throwing. So there was no issue of infection control or quality of the work you were doing. So it was really a simple project to start with. And that was really encouraging. So that's why I'm saying start with simple projects, because you can have a success and then everybody think, oh yeah, that can actually be done. And then people try to, do something else, and that's how things move forward. Yeah.
It's true. It's nice to have some little successes to keep being inspired. So we are already 5 minutes past, so I might close the session now, even though we still have questions and we could go on talking about this issue for a long time, I guess. But thanks so much for the speakers, for the participants. For the participants, please do fill our post-training survey. It will help us a lot in the future. And don't forget to register for our webinar next week if you're interested in the health aspect of plastics. Thanks again very much to everyone.